All right, welcome back everybody to Season 3, Episode 6 of the Building Lifelong Athletes podcast. I'm your host, Jordan Rennicke. Thanks so much for stopping by. I really appreciate it. Today we're talking all about NSAIDs, or non-steroidal anti-inflammatory drugs. So we're going to talk all about these injections more specifically. So we're not talking about the oral medication, but talking about these injections. So we're going to talk about things like the pharmacokinetics, the chondrotoxicity, when to use them, what my thoughts are, all about that. So let's dive in right now. So first, let's talk about pharmacokinetics, right? So pharmacokinetics is a fancy word for essentially how these drugs are metabolized in our body, right? So pharmaco meaning, the medication, kinetics and how it works and so how it moves. And so this is talking about stuff like half-life and bioavailability, all this fancy stuff, but all it's really saying is, hey, when we take this medication, how does it work? And so first, let's break down the root word NSAIDs. That is non-steroidal anti-inflammatory drugs. So we've talked about steroids, right? We talked all about that last time. These are non-steroidal, so there's a different mechanism for how they work. What they do is they prevent the conversion of arachidonic acid into things called prostacyclins, prostaglandins, and thromboxanes. So we are inhibiting these being made, and they're done so by inhibiting the cyclooxygenase pathway, or the COX pathway. Like I said, sorry this sounds a little deep, but we're just helping differentiate why we choose one injection versus another and what the mechanism is. So once again, when we are on these NSAIDs, we're trying to inhibit the pro-inflammatory things like the prostaglandins, prostacyclins, and thromboxanes. And we do that by inhibiting this COX pathway. And it's not just one simple enzyme. There's actually two main enzymes, COX-1 and COX-2. There are others, but those are the main ones. And the different medications we have, some are more specific to which COX they inhibit at the end of the day. So like I said, the COX-1 inhibitors that we think more like in terms of hit those receptors are the ones like diclofenac, naproxen, aspirin, ibuprofen. So our most common NSAIDs. They'll do both actually. Like they'll inhibit 1 and 2. Like I said, it's not specific, but the reason why we talk about these thinking about 1 is because the other COX-2 inhibitors that are more selective do predominantly only COX-2. So like I said, you are going to get 1 and 2 with the common ones like ibuprofen, naproxen, diclofenac, all that. But then when we talk about COX-2 ones that are more selective, we're talking about celecoxib and meloxicam. These are more likely to inhibit COX-2. Once again, we will also have some COX-1 inhibition as well, but it's actually like 50 times more preferential for COX-2. So like for every one COX-1 that's being inhibited, 50 COX-2 are being inhibited. So once again, that is why they're more COX-2 selective. Those are not as common, in terms of going over and getting those, picking up at the pharmacy by over the counter. Not going to find those necessarily. Whereas all the, ibuprofen and whatnot you'll find there. So the question you might be asking is like, well, Jordan, this is super nerdy and boring. Why do I care about this? Well, we care about it because specifically COX-1 is expressed everywhere, pretty much throughout the body. So kind of all over. The things we really worry about is they're expressed in like the gastric mucosa, so the lining of our stomach, and in our kidneys and other places as well. And so, like I said, we have some spots there where it can lead to issues, and we'll talk about those. The reason we care about COX-2 inhibition only is because it's limited to fewer tissues. It's not as diffuse as COX-1. And like I said, and COX-2 is usually increased, the expression is increased during inflammatory processes. So when we're having inflammation going on in our body, we have, an increase in COX-2. And so if we are just selectively going for COX-2, we're saying, okay, we're not going as widespread in the body. We're maybe not hitting the gastric mucosa, maybe not hitting the kidneys as much, and we're going directly for the inflammation. Like that sounds like a win-win. Like I said, we care so much because if we continually take NSAIDs, even with injection form, like I said, but this is more, the data is more on the oral forms, but if we take NSAIDs over and over, we can have irritation of our stomach. It can lead to ulcers. We can also be hard on our kidneys, can lead to kidney injuries. And so we care about that because, man, that's not a good thing to have. We don't want to be taking one medication and create more problems. And so that's what we worry about. And that's why when we have that COX-2 selective ones, we're hopefully decreasing the side effects that we have, and then also focusing on the pro-inflammatory COX pathway that's known to happen during inflammation. We're trying to block that as well. So we'll also talk about the half-life during pharmacokinetics. Half-life is essentially how long it takes till about half the medication is gone in your system. And so specifically we're looking at, what they look like from injection versus oral form, right? So ibuprofen, half-life's about 1 to 2 hours, right? So how do all this compare though with when you take it by mouth or when you inject it? So like I said, about 1 to 2 hours normally, that's fine. If we look at the bioavailability, meaning how much that's available, it's actually pretty similar between an intramuscular injection and an oral pill. So there's about 90 to 100% availability. So like I said, it's pretty much the same with oral or with an intramuscular. Like I said, that being said, about 25 to 50% of that bioavailable medication is found in the synovial fluid. So let's take a step back here. If we're getting some sort of NSAID by either an oral pill, so we take some ibuprofen, or an injection intramuscularly, like I said, the bioavailability is about the same. That's going to be good. But of that bioavailability, only about 25 to 50% of that concentration that's available is found in the synovial fluid. So what we're saying is, the medication we're taking, we're not seeing nearly as much in the synovial fluid, but that's pretty normal because it's not as widespread, right? It's not that close to the blood supply, and that kind of makes sense. And so what about topical NSAIDs as well, right? We have topical NSAIDs, thing called, it's a diclofenac gel. Usually you can buy it over the counter now. This also is an option for us because it has less systemic exposure. So we talked about before that percentages, right? There seems to be only about 6% of that concentration is absorbed systemically by these topical ones. And then on top of that though, we actually have an increased percentage in the synovial fluid. So overall systemically absorbing only about 6%, but inside the synovial fluid that we sample, about 50 to 80% of that concentration is seen. So it might be like a lot of words, like what's going on? What I'm saying, just to reiterate here, kind of going back and forth, is you take oral or you take into the muscle, their bioavailability, really good. It's going to get there, but you're not going to have nearly as much in the joint. You do topical, you're going to have less systemic absorption, so less without throughout the rest of your body and at other sites, but you're going to have more in the fluid at the joint that you're putting it at. So like I said, that's kind of where we're looking at. And it's like an overall, like I said, if we kind of take a step back, 10,000 foot view, the exposure of NSAIDs is similar between if you give it in your muscle, if you get it in IV, if you take it orally. Like I said, there's all those different factors. And what about though if we inject it into the joint? Well, into the joint's a little bit different. We do see about a 2 to 3-fold increase in the maximal synovial concentration compared to oral for a one-time dose. So if you're saying, hey, I'm comparing a one-time injection of a non-steroidal medication versus, hey, a one-time dose of oral NSAIDs, you're going to see a 2 to 3 higher increase inside the synovial fluid. So like I said, we're going to see more, which makes sense, right? If we're injecting into a joint, we're probably going to see a higher concentration there. So that's what we expected. But here's the big caveat. So we have 2 to 3 when it's only one for oral or one for intra-articular. But if you take oral NSAIDs for about a week, which is a pretty standard way of doing it, right? You say, hey, let's take this for a week, kind of calm things down. So let's take it for a week. The dosing there would actually produce 10 times more synovial concentration compared to the one-time injection, which kind of sounds not intuitive. But like I said, if you do an oral one for a week, the concentration is going to build up enough where we actually have more concentration exposure to the joint than just a one-time injection. And so once again, I do want to make sure that I'm cautious in saying that just because we find a higher concentration inside of the joint does not necessarily mean it's going to be more efficacious, right? Doesn't mean it's going to work better necessarily. But that being said, we're talking all about, are we getting this? And so that's just something to think about. One dose versus one dose seems to be less in the joint with orals, but then if you give it for a week straight after just that one injection, if a week of orals is probably going to lead to a higher concentration. But that being said, I also want to mention that systemic absorption, right? So these NSAIDs, if you inject it in the joint, is it just going to stay in the joint? No, that's not true either. There's about 80% of bioavailability that we find, or kind of 80% concentration inside the systemic blood system. So once again, if you inject it into the joint, you're still gonna get it systemically. So it's not just gonna stay in one spot. And so like I said, all the side effects that you could have from any other NSAID also still applies to an intra-articular injection, which seems weird, but like I said, that seems to be what the data shows. And then I also want to touch on chondrotoxicity. So we've talked about this before, had a whole different podcast about this, but chondrotoxicity meaning damage to the cartilage inside the joint. Are these chondrotoxic? We know steroids are chondrotoxic, right? We've talked about that. And so are NSAIDs? Well, there's some studies. Let's look at oral NSAIDs first. There's some studies showing there's an association between oral NSAIDs and the medial joint space loss when comparing an X-ray, right? So they took a study where they said, hey, we're going to put these people on some oral steroids for a pretty prolonged time. And they're going to repeat X-rays and see what happens. And they found that there seemed to be a decrease in the joint space of the knee. So saying, hey, if we see decreased joint space in the knee, that means the cartilage must be getting worn away. So that's what we're kind of saying. Might be happening there. But the question for that is, are we capturing the people who use them because they have worse disease to begin with? So like, is it the NSAIDs actually causing it, or do they have a worse disease, therefore causing them to take NSAIDs more, right? And then there, because of that, we see progression of the arthritis. So it's not necessarily clear, but like I said, there's some association with it, and I just want to talk about that. And then from an intra-articular perspective, there is a positive research. There's not a lot of research saying, hey, does intra-articular NSAIDs lead to chondrotoxicity? There was one study that showed that single doses of Toradol did show significant in vitro chondrotoxicity, right? So once again, we talk about how those work. We kind of take out some usually cartilage cells from a surgery they're doing, put it in a petri dish, kind of simulate the environment of a normal joint. And then from there, they inject different medications, and they did seem to have an increase in chondrotoxicity when we inject Toradol. So Overall, it appears like there might be some chondrotoxicity, although the data is not as robust, right, as steroids. And so there's just a lot less research, so it's hard to make heads or tails of anything. So when I kind of think about it, right, I think that this is a lesser known, right? There's not as much study, but it potentially doesn't seem to be as slam dunk. And so it might be an option where it's less chondrotoxic than steroids, but we're not quite sure. I can't confidently say that at this time. And so now we're going to talk about, hey, how do these compare to NSAIDs or to steroids? I'm sorry. So we have our NSAIDs, right? And then our steroids. Under that umbrella of anti-inflammatory injections, we have steroids, we have NSAIDs. How do they compare? Well, like I said, once again, the theme here is there's just not a lot of data, unfortunately. Like, holy cow, I was looking through this, expecting to be pretty robust, and it is not. There's not a lot. There's some studies here and there looking at things, but not a lot, which is very unfortunate. But one I did find was looking at hip osteoarthritis. So we looked at steroids versus NSAIDs in the hips. The dosing they were looking at was 40 milligrams of triamcinolone versus 30 milligrams of toradol, which are both pretty standard dosing. I mean, essentially, usually triamcinolone comes in 40 milligram concentration. So 1 cc is usually 40 milligrams versus toradol, 1 cc is usually 30 milligrams. So pretty standard dosing there. What they're looking for is that both treatment groups were successful. So there were successful treatment groups, and they were not significantly different in their outcomes at 1, 3, and 6 months. And like I said, and usually these outcomes are pain and function. And, they said about 70% of people had improvement at 1 month, 52 to 56 at 3 months, and then 41 to 46% of people had improvement at 6 months. And so overall, though, greater than 50% of people had improvement in pain, and greater than 20% had improvement in function at 6 months. And so once again, very similar results, though. And so, like I said, though, one reason I consider this as a kind of a worthwhile study is because we know, like I said, the chondrotoxicity of steroids, and there's actually some concern that when we go specifically in the hip, we tend to have an increased risk of avascular necrosis or breaking down of that bone a lot faster. And so if we can do an NSAID, which may not be as chondrotoxic potentially, that might be an option, which would be kind of cool. But like I said, we know that steroids in the hip are kind of a high risk procedure occasionally, especially if we repeat them over and over again. And so, like I said, it's not necessarily at the one-time dose, but repeat dose is really when we worry. But like I said, it's an option to have something there. So you might be picking, a lesser of two evils potentially by doing an NSAID. So then let's talk about knee osteoarthritis, right? So once again, looking at steroids versus NSAIDs at knee arthritis. Once again, not a lot of studies. I'm shocked. I was actually shocked that there wasn't a direct comparison of NSAIDs versus steroids, but that's what it is. They kind of had a different design where they had viscosupplementation used with either a steroid or NSAID, right? So we talked about the hyaluronic acid derivative injections. So they did that injection with either a steroid or an NSAID, and then they did that once every week for 3 weeks is what it was. And at the end of the day, there was no difference in pain or functional outcomes when compared at 3 months. And so not a whole lot of data going on there. Once again, doesn't seem to be substantially worse than an NSAID anything. And once again, no direct comparisons, which I thought was generally shocking. There was also one study that kind of showed similar efficacy looking at oral tanoxicam versus intra-articular. So they're saying, hey, if you take oral medication, so oral NSAIDs, which tanoxicam is not a very common NSAID, so I don't know how translatable this is, but studies showing that if you take oral tanoxicam versus an intra-articular injection, which the injection was each week for 3 weeks, said at the end of the day, the takeaway was that they had similar results, which meaning that they had, similar pain and functional outcomes, and maybe had some less systemic effects with the intra-articular injection as opposed to 3 weeks of steroids, but that's something to consider as well. Once again, should we be doing intra-articular or should we be doing oral? It's a really good question. Also talking about trigger finger next, there is a couple articles on trigger finger. There's actually a Cochrane review on that enough, which, like I said, Cochrane review is usually like, whoa, lots and lots of stuff, but it was just a couple articles they looked at. But I was excited about that. I thought this is pretty dope to have a Cochrane review on intra-articular. It's a subsection of trigger finger general treatment, but hey, I'll take it. And they looked at NSAIDs for trigger finger and then looked at it specifically for injections. And they showed by 24 weeks, results from 2 different trials show that NSAIDs offered little to no benefit when compared to steroids. No real difference in resolution of symptoms, recurrence, total active motion, residual pain, patient-determined success, or adverse outcome. So essentially about equal, which, I mean, the way you look at it, you could say, oh, it's no better than steroids, or you could say, hey, it's just as good as steroids, kind of depending on what lens you're coming with there. So this is kind of how I approach this, right? So you're saying, oh, well, Jordan, that was once again, a really depressing episode. There's not a whole lot of takeaway there. And once again, I'm just bringing, don't shoot the messenger. I'm just bringing up what I see in the literature. And like I said, I think it's a call for more literature in the sports medicine community. But like I said, I'm very thankful for what we do have and the people working really hard. But like I said, sometimes we do the things that we do, and are they evidence-based? I'm not sure. And that's why I'm trying to dig to the bottom and figure it out. So how do I approach this? Like I said, there's actually no FDA approved indication for toroidal arthritis, which is kind of shocking. Steroid is approved, but we're essentially using everything off label. So we kind of have to be aware about that. Like I said, I do think it is reasonable to use these. I think there's enough data showing that, hey, they seem to be safe. So I don't think it's a dangerous experimental injection by any sense of the imagination. But like I said, the evidence base on this is not very high. We are not just going to be sitting on mountains and mountains of evidence to defend what we do. And so we're kind of going off in the weeds a little bit here. But like I said, we do have some rationale and some evidence base for like why we do the things we do. And you have to have a rationale for why you do things, right? So I do think it is reasonable to use this in place of a steroid injection, right? The way I think of this is a potentially quote unquote less bad option. Like I said, I do not have enough data to say this is definitely better in terms of chondrotoxicity. Like I said, but multiple different studies have shown that, hey, it does not seem to be inferior to steroids for certain things, like, short-term outcomes for arthritis. And so it is reasonable to do that if someone has a contraindication to a steroid, right? So we're going to use steroids and NSAIDs pretty much for the same reason, right? We're just trying to get temporary pain relief. And so that's kind of what we're thinking about. When we use these with that frame and that lens of mind, it's okay to kind of use them as needed. And once again, we're going to use our brains here, right? We're going to talk with our patients. We're going to talk with your doctor. We're going to do that, try to figure out what is the best option for you. And one thing I want to talk about too is who shouldn't get one. Well, I think if you have a history of heart disease, right? Cardiac history, NSAIDs are usually not a good idea. If you have a bleeding history of kidney issues like chronic kidney disease, or history of ulcers, I would probably stay away from these injections. Like I said, NSAIDs still have that systemic effect, can have issues with that. It is a one-time injection, so not nearly as problematic as if you're taking oral NSAIDs every day. But like I said, something to steer away from. And so my practice, how do I use these? Once again, like I said, I kind of use these as an adjunct or an alternative to steroids. So let's say someone, maybe steroids doesn't seem like a good idea. Like they're super young, and we're worried about, hey, we want to make sure that the cartilage is preserved as much as possible. We know steroids are bad, right? We do not know that NSAIDs are necessarily better by any stretch, but like we don't have any data saying they're worse from that perspective. And so it's one of those things that might be the better of two bad things. I'm not sure. But once again, we're doing it from the same reason that we are just trying to get temporary relief to allow someone to get back to do what they want to do. This is not a long-term fix for pretty much anything. And so we have to consider that always. On top of that, maybe I'll use someone when I think a steroid is contraindicated, someone who's having poorly controlled blood sugars, right? That might be an issue. Or someone who has, some other reason for they don't want to get steroids. And so this is something I would think about. Like I said, we're going to still use it from the same lens. If we're choosing between anti-inflammatories, then this is the option that we're going to choose. And so just something to think about. So like I said, that's kind of how I've used these. This is the literature that I've seen. Not very impressive literature, but like I said, I just want to share that with everybody so we can kind of make some more informed decisions. So I really appreciate you listening. Thank you so much though for stopping by. If you did enjoy it, it would mean the world to me if you liked, commented, shared, subscribed, or share this with a friend. That would be awesome and get the word out. So thanks again so much. I really appreciate it. Now get off your phone, get outside, and enjoy the rest of your day. Take care.